Good morning, all. Good evening, all. Good evening, all. Today, my topic is an abstract present in ASCO this year, Tepotinib in patients with advanced non-small cell lung cancer with METamplification. As already previous speaker has spoken about, MET is a proto-oncogene which is located on 7q chromosome. It is a receptor tyrosine kinase, the ligand being hepatocyte growth factor, and the activation of receptor tyrosine kinase by binding of ligand hepatocyte growth factor will lead to downstream signaling of RAS, RAF, and PI3K pathways. So abnormal signaling of this MET pathway lead to increased cell proliferation, survival, invasion, and metastasis. The MET amplification is also one of the potentially actionable and primary oncogenic driver. It is different from the MET14 skipping mutation which has been previously spoken of. It occurs in around 1 to 6% of non-small cell lung cancer patients and up to 20% of patients who had acquired resistance to EGFR TKI. And MET amplification is a negative prognostic factor, and higher the level of MET amplification, higher the objective response are identified with MET TKIs. In the abstract, they have described the cohort B of the Vision trial, which included actually this Vision trial included MET14 skipping alteration, and in the cohort B they have included MET amplification. So the inclusion criteria is locally advanced metastatic non-small cell lung cancer with ECOG 0 or 1 who have received prior 0 to 2 lines of therapy and who are EGFR ALK wild type and who had no exon 14 skipping mutation. The MET amplification has been diagnosed by liquid biopsy using the Guardant 360 technology, and the positive MET amplification is taken as anything more than 2.5. The ratio of MET to CEP more than 2.5 is taken as positive for MET amplification. So the intervention is Tepotinib. It was given at a dose of 500 mg OD with food till progression or toxicity. The primary endpoint is overall response rate, and the secondary endpoints they have looked at duration of response, progression-free survival, and safety. This is the number is small. Total number of patients included are 24. The median is 63. As we see, the MET14 skipping mutation has a higher age, whereas MET amplification, the median age is around 63 years. Predominantly are male, 88%. Predominantly are ECOG PS1, 88%, and predominantly are smokers, 88%. So among the 24 patients, 7 patients received Tepotinib in the first line, 42% in second line, and 29% in the third line. So after the data cutoff is around November 2020, and by that time the treatment is ongoing for more than 1 year in 5 patients, 2 among first line, 2 among second line, and 1 in the third line. The objective response rate by individual independent review committee is 42% overall, and 70% in the first line, 30% in the second line, and 29% in the third line. And the median duration of response has not reached, and the objective response rates are similar by investigator assessed outcomes. So this is the table showing the outcomes with Tepotinib. As I have already told, around 42% in the first line, and 71% in the overall 42%, 71% in the first line, 30% in the second line, and around 30% in the third line had overall response rate. The duration of response is the median is not estimable in overall population, and the PFS median PFS is around 4.2 months in the overall population, and it is not estimable in the individual subgroups. The treatment-related adverse effects include 67% overall, with grade 3, grade 4 being 29%, the most common being peripheral edema. Other common complications included generalized edema, anasarca, and constipation, and the discontinuation rate due to unrelated adverse effects is 20%. So this is a table comparing various TKI inhibitors which has been used in MET amplification. So in this our vision cohort B with tepotinib, 40% overall response rate has been shown with a median PFS of around 4.2 months with grade 3 or high adverse events being 29%, of which peripheral edema is common. In the previously spoken geometry trial, the cohort 1A and 5A included MET amplification where the ratio is more than 10 in previously treated and previously untreated patients. When the capmatinib is given, the overall response rate is around 30 to 40% in 30% in previously treated and 40% in previously untreated, with a median PFS of around 4 months. In the cohorts with the MET amplification less than 10, they are closed early due to poor overall response rate, which is about 7 to 10%. And with crizotinib in the patients, in profile 1 study with MET amplification more than 1.8 months, they have shown a 28.9% overall response rate with a median PFS of 5.1 months. They are further divided into different groups with an MET amplification more than 4, response rate is 38%, with 2.2 to 4 it is 14%, and with 1.8 to 2.2 it is 33%. If we compare our results with the metexon and 14 skipping mutation with the tepotinib, the overall response rate is around 46%, and PFS is around 8.5 months. So the tepotinib is not approved for this indication in MET amplification patients, but this is the response rates are comparable with that of tepotinib in MET exon 14 skipping, and it is better than capmatinib and crizotinib in this subset of patients. So that's tepotinib showed high and clinically meaningful activity, particularly in first line, and is generally well tolerated. Thank you.